Hi, good afternoon. This is Jim Greenblatt, and we're going to be talking this afternoon about OCD, Obsessive Compulsive Disorder, in kids and adults, and some integrative nutritional approaches that I think have been very effective over 28 years of practice. So let's start off with our psychosurgery slide, because in Boston, and actually Providence at Mass General and Brown, they have very active surgery programs for the treatment of OCD, because it is such a treatment refractory illness, and these are marketed, and many patients come asking me write a letter so they can get neurosurgery, brain surgery for OCD that's been unresponsive to treatment. And our last attempt at psychosurgery was lobotomies, which Dr. Moniz, you can read here, won the Nobel Prize. So a frontal lobotomy that we're all familiar with from One Flew Over the Cuckoo's Nest. The gentleman won the Nobel Prize, and the irony, if you will, he was shot and killed by one of his patients and died. And this is from the brochure. I think at the Brown, either Brown or Mass General Harvard programs. We don't like to call it psychosurgery anymore. It's neurosurgery for severe psychiatric illness. OCD is one of them. So I think we can do a better job. These are some overview slides I'm going to go through quickly. But we have obsessions and compulsions. And patients with OCD are aware that their thinking and behavior are abnormal, but feel powerless to change their thinking and behavior. And that's the difference between a delusional disorder or psychotic illness. And the obsessions are the thoughts. These are the recurring ideas, images that intrude. You know they're irrational, but it is very hard to suppress them as they intrude into one's day. Most common obsessions on the left are contamination, doubt. Pathological doubt is common in kids, where they're asking, Mom, is Dad coming home tonight? Is Dad coming home tonight? Or did I, do my homework? Aggressive impulses and sexual impulses. And then some of the other obsessions you can see, religious convictions are probably one of the more common, but this page could be filled with other kinds of obsessional thoughts. But again, recurrent ideas, thoughts, images that intrude into the mind. And the compulsions are the behaviors. These are the behaviors or the rituals that individuals use to kind of dispel the anxiety, and it is very hard to stop. Individuals feel compelled to perform these compulsive behaviors, and here you see some of the compulsions: counting, hoarding, touching, checking. Again, it's the behavior. So the most common obsessions are the four here, and the most common compulsions. But again, you might not be in the top four, but completely debilitated by the obsession. Again, we recently had a woman that we saw whose obsessional thoughts were around kind of body image, and the compulsion was running. So she'd be running 20, 30 miles a day. She couldn't stop herself, and actually attempted suicide as a way of stopping this uncontrollable OCD behavior. Many forms of OCD, eating disorder, body dysmorphic disorder, hypochondriasis, always concerned about one's health. Here's some of the old school. Not everyone who suffers from OCD has every symptom, and the symptoms can change over time. It's kind of a chronic relapsing course. You can have good weeks and bad months, good years and bad years, but it is debilitating. Talked about high rates with other psychiatric illnesses, eating disorders. A field that I spend a lot of time with, I believe, is close to 100%. The research is more like 50%. For years, when I was in training, we missed this diagnosis a lot because people thought you had to have obsessions and compulsions, and so many debilitated patients we're treating might not have any compulsive behaviors, but they have these intrusive thoughts they can't get out of their head, or vice versa, having the compulsions to do things without the thoughts. You don't have to have both. One of the few psychiatric disorders where men and women are equal. 1/3 of the cases begin early onset. Most onset is young adulthood, and it's the fourth most common psychiatric illness. We're seeing increasing numbers of young children, very young children, 5-, 7-year-old kids with pretty classic signs. One particular patient, very, very strong family history. When we saw her at 7.5, her symptoms began at 4, but it was hand washing, praying. The obsessional thoughts was if she didn't do certain rituals, that other people would get sick. And I mentioned some of the violent thoughts and some of the sexual thoughts. I think some of our sexual predators had early onset OCD. I watched this special on Jeffrey Dahmer, a serial murderer, and he talked about a classic childhood of obsessive thoughts when he was a young child. He started having obsessive thoughts about violence, and that was intermingled with sex, and it got worse and worse. When these obsessive thoughts appear at a young age, 4 to 7 years of age, it becomes normalized. The child doesn't know any different, and developmental cognitions, if you will, the developmental course is based on these obsessional thought processes. So my point here is that we need to treat this aggressively. We need to treat it early, and I believe the biological illnesses, we've disproven the psychodynamic, very strong genetic component, and a neurobiological component. No theory really stands sufficient, but certainly the genetic and neurobiology is getting better understood, and usually most of the research points to abnormalities in serotonin neurotransmitter system. Let's keep going. So in our world of integrative therapies, I don't have a cookbook. I don't have a simple answer. We've seen individuals suffering from very significant OCD with abnormalities in all the above in the slide in front of you, from thyroid disorders to amino acid deficiency. And we'll go through some of them. This is kind of my slide of some of the things that we'll talk about a little bit tonight. Probably the most common that we see in our practice, folate B12, enhancing serotonin with 5-HTP, using inositol probiotics, vitamin D, DPP4 breaks down casomorphin, and zinc and magnesium. The other one that's becoming increasingly, I think, common as well as better diagnosed is PANDAS. These are strep infections with neuropsychiatric sequelae. OCD and tics are the most common. We've also seen significant eating disorders, and now with better research, it's not only strep infections, it's multiple bacterial infections that can contribute to neuropsychiatric disorders due to cross-reactivity with brain tissue. So typical treatment is behavior therapy, psychotropics. They both work. They work to some extent. But again, with a chronic relapse and course, it never gets to the underlying cause. The behavioral therapy literature is quite good, and we've seen brain changes in PET scans of those that consistently do behavior therapy. There's a modest improvement with medications, not consistent. Here you see SSRIs and epinephrine being the most common. 80% of patients improve to some extent, but only about a 50% reduction, and those are individuals that continue on their medications, which are not very common with OCD. When you think about somebody who's obsessively worrying, either about their health or about side effects, the vast majority of OCD patients that I have treated, just getting to take medications is a challenge. And usually when they take a medication, they'll quickly stop because they associate a symptom, any new symptom with the medication. So we talked about that. So let's get to try to understand. The biology is continuing to focus on deficiencies in functional deficiencies in the serotonin transporter system. And there are many ways that we can affect this serotonin transporter system. And that is genetics. We know there are different genes about how we break down serotonin, the transporter system, as well as we'll talk about genes related to cofactors in the synthesis. Nutritional deficiencies we'll talk about, inflammation we're going to talk about, stress we're going to talk about, neurotoxins we're not going to talk about as much. But I just wanted to paint a broad picture of all the potential insults that we can find in a healthy serotonin system. So I'll kind of refer back to these kind of 5 concepts. We're not going to get through all of them, but just so you understand that it's never simple, but we're looking for different ways to enhance serotonin or to compensate for genetic vulnerabilities. So many of you have seen this before. This is 2 neurons with serotonin being produced in the presynaptic cell from tryptophan, which goes on to 5-HTP, and then the receptors in the postsynaptic cell. So if we think of this, we can look at many different ways in this pathway that would affect serotonin. And I'm just going to focus for a few minutes on some of these. So tryptophan is the precursor molecule, and we can use tryptophan as a supplement. Tryptophan, I think, can be very helpful, primarily for sleep and for kind of mild OCD in young children. The problem with just using tryptophan is that it has a feedback mechanism, and so after a certain dose, the blood-brain barrier says we have enough tryptophan and turns off the carrier molecule. That's why sometimes we'll use 5-HTP, and you see that down below. So 5-HTP does not have that feedback mechanism, so it is quickly crosses the blood-brain barrier with adequate micronutrients, zinc and B6. It goes on to make serotonin. So for the vast majority of our patients with OCD, if we're talking about amino acid precursors, we're looking at 5-HTP. If sleep is an issue, sometimes we'll use tryptophan before bed. But what we see here, there's so many other factors that would affect the synthesis of serotonin. And we're going to talk about some of them. We don't have time to talk about all of them, but let's quickly just mention them. So folate here, Folate is the rate-limiting step in the enzyme conversion, and there are multiple genetic defects for the MTHFR gene, so that would affect serotonin synthesis. Vitamin D, you see, is also critical for that tryptophan hydroxylase enzyme, TPH. So if vitamin D is low, you're not going to be able to have the cofactor for that rate-limiting step. And then you see the B6 and the zinc. You can think of zinc deficiency due to environmental toxins like phthalates. You can think of vitamin B6 deficiency due to cryptopyrrole, pyroluria. So again, multiple areas, both genetic and nutritionally here, that would affect serotonin synthesis. So we have to be careful just saying for OCD, we have this nutritional intervention. Just take 5-HTP, it helps OCD. That's what you're going to read on the internet. And the problem is that's what a number of our colleagues are just saying. And it's never that simple. And what hopefully you'll get in today's presentation is that serotonin synthesis could be a major factor, but there are other factors we would need to consider. This is just showing the importance of digestion and the first breaking down protein to the amino acid tryptophan is through having adequate hydrochloric acid in the diet. Hydrochloric acid is produced in the stomach with adequate zinc to help make the enzyme. So you eat the protein, the chicken or the fish, with a glass of milk, you need adequate acid to break it down to the tryptophan so we can develop the precursor molecule to serotonin. I would say the vast majority of the patients we're working with, digestion and low hydrochloric acid is a factor. Here I mentioned earlier 5-HTP, sometimes better than tryptophan for OCD. And here I mentioned the nutritional factors. So working with pure encapsulations and New Beginnings have these supplements in an effort to try to get some of the precursor molecules to serotonin. We developed this supplement that has all the cofactors as well as what we're going to talk about soon, inositol and taurine. B12. Very simple. Many of you already test for it, understand it, but I believe there's a direct correlation with many of our patients suffering from OCD. B12 deficiency is kind of fascinating to me because 10 individuals with low B12, based on elevated methylmalonic acid or serum levels of B12, they might have different symptoms. We can have psychological symptoms. Anxiety and OCD is not uncommon. And again, working in an eating disorder population, we see hundreds of individuals with OCD, and we look at B12 levels every day. So correlation with psychological symptoms and then physical symptoms. And we can't predict. Some individuals might have just fatigue and depression. Other individuals might have tremors or some combination of the above. So I don't think there's one clinical symptom profile for OCD, for B12 deficiency. That's why it's just so important that we test. And my pet peeve about about B12, I'm sorry, is the reference range. For most lab tests, it's 200. Sometimes it's 230. Some I've seen 190. But this broad range around 200 to 1100. This is a Quest slip, which now reports levels of 2 to 400 having neuropsychiatric symptoms. In my experience, under 500 should be treated. Often we treat the serum levels for B12 regardless of what the absolute number is if there are other markers like elevations of methylmalonic acid, either from the organic acid test or serum levels. So B12 levels, reference ranges, I believe, are critically off, and I am aggressively treating our patients with mostly IM or sublingual B12, hydroxycobalamin, methylcobalamin, to try to get levels way up over 500. But B12 has been a consistent nutritional deficiency in OCD that's seen for many years. It is critically important for methylation of serotonin and other neurotransmitters. So here's just another schematic of our synthesis of serotonin from tryptophan. But I just wanted to take a few minutes to talk, about inositol. So inositol is a nutritional supplement. It's used for the treatment of anxiety, depression, and OCD. There's lots of kind of misinformation of inositol, but we can think about it as the second messenger system. And that's how it's described biochemically. If you see serotonin is labeled as a first messenger, it's released from the presynaptic cell, it hits the postsynaptic cell, and the changes in the cell release inositol that you see here. And inositol becomes a intermediate, and it affects many neurotransmitter systems, but serotonin system is one. The good news, if you're trying to give it to patients, is that it's very similar chemically to sugar, glucose molecule. So if you see the chemical structures here are similar, which means it tastes good and it's very palatable. So you can mix in water or juice, and young children and patient adults will find it very palatable. Here's a little bit of the history. The early studies started showing low levels of inositol in their cerebrospinal fluid of patients with depression. And then they were able to raise those levels by giving 12 grams a day. And then depressed patients were treated with inositol. And these were double-blind, pretty well done studies, not high volume in terms of patients, but well-controlled studies with improvement noted. So from the depression studies, they started looking at anxiety and OCD. They one study here, 13 patients, again, double-blind, placebo-controlled trial. Since the depression studies were done with 12 grams, they chose 18 grams, which was just randomly chosen, which is a lot of inositol. It's at least 2 teaspoons 3 times a day for the powder inositol. And then they did OCD and depression and rating scales up to 12 weeks. And there are no side effects in this study, although other studies had side effects we'll talk about. But there was significant improvement compared to placebo at the 6-week marker. So inositol, 18 milligrams per day, divided 3 times a day, showed improvement in symptoms of OCD. Since then, there's been lots of other research looking at OCD and major psychiatric illness, and the research has consistently kind of shown the same pattern, that those illnesses that were responsive to serotonin reuptake inhibitors, anything that increases serotonin, inositol seems to help. And that's been depression, OCD, panic disorder, and bulimia. The panic disorder study was actually well done compared to medication. inositol worked just as well. The studies that were negative were schizophrenia, autism, Alzheimer's, ADHD. So over the years, they really did look to make sure there wasn't a one placebo effect or two, just a global effect on many of the major neuropsychiatric illnesses, which there wasn't. Depression, OCD, bulimia, and panic disorder are the most responsive to inositol. Let's go through a few cases and then I'll kind of summarize. This was an 11-year-old having mild OCD and worry since he was 4, but it just completely got increasingly incapacitating for him, and fears of fire and contamination, of bad things happening to the family. So something triggered this. I believe there was a fire in either a relative's house or somebody that he knew. And then the OCD got just debilitating. So he couldn't sleep at night because he was up all night. He stopped playing with his friends. And here, starting off with low dose, I start off kids with 1/4 of a teaspoon. I start off adults with 1/2 teaspoon, increasing it to 3 times a day, a total of 4.2 grams. Again, not to 12 or 18 grams. And this is the mother's quote, amazing, a different child. So we didn't need to use medications. We didn't do a lot of other testing for this boy. The family couldn't afford any other testing. The insurance wouldn't cover basic screening. So inositol by itself, amazing different child with 11-year-old OCD. There are other kids. This was a 9-year-old that we needed to use inositol and 5-HTP. So I would only start with one at a time, but minimal improvement with the inositol, adding 5-HTP 3 times a day, significant improvement. And this was a 7-year-old, not throwing out garbage. I should bring home soiled toilet paper from school, garbage in the room that got increasingly debilitating. And like many of these kids, seeing a psychiatrist, she went through multiple medications, mostly SSRIs. Besides the weight gain, 40-pound weight gain, she tried to suffocate herself on the Prozac. With this family, we looked at inositol 3 times a day. There was some improvement, but not sufficient, so we needed more. And that's where we looked at these neuropeptides, and they were elevated. And now I want to talk about that. So many of you might have looked at these, but if not, I really encourage you to understand the opiate peptide test, the urine test. It's an add-on from the organic acid test. Basically, we're looking at levels of casomorphine, which is a peptide derived from the milk protein casein, and we're looking for gliadorphin, which is a peptide derived from gluten. Here's one of the first cases we had with OCD. This was a patient in her 20s when she came to us. She was a young patient, early 20s, and this is a quote from the chart. 16 years old, she recalls being depressed at the time, but could not pinpoint specific thoughts other than that she needed to eat flour. The patient associates flour with feeling relaxed and soothed. When we saw her, she was eating 1 to 2 pounds of flour a day. She's been up to 4 pounds of flour a day. So she mixes a flour with water to make a paste, and she eats that, as you see here. So 24, not 21, 12-year history of an eating disorder, OCD. She also had trichotillomania. These are some of the other illnesses we've seen with elevating of these morphine analogs, if you will. So let me try to kind of go into detail for those of you who aren't familiar. So casein, again, it's a protein in milk. It's in dairy. So we see it in cheese, in milk products. Our body breaks it down to casomorphine. We all go through that phase. And if we have adequate digestive enzymes, DPP4, a zinc-dependent enzyme, it's broken down to its amino acids, and we absorb the amino acids. If you don't have adequate DPP4, you're not able to break the casomorphine down, so you get these peptides that are released into the digestive system, crosses the blood-brain barrier, and we know they have CNS, they have central nervous system acting effects. If we inject them into rats, their behavior changes dramatically. If we put a blocker, an opiate blocker, like naltrexone, before we inject the casomorphine in the rats, they won't have the same reaction. So it's pretty clear, both based on animal studies, that casomorphine, gliadorphine are these peptide analogs that cross the blood-brain barrier and have pretty dramatic CNS effect. And that's why when I showed you these slides here, lots of psychiatric symptoms associated with elevations of casomorphine, I've just found very common OCD. So these are some of the cases that I talk about. We had a bodybuilder who was taking bodybuilding formula. Now, 100% pure whey should not have much casein in it, but these bodybuilding formulas are very cheap, and casein is cheap. So as he started doing these bodybuilding powders 3 times a day, he had mild OCD that got so severe he couldn't get thoughts out of his head about murdering his parents. Now, this was a great kid who was scared by these thoughts and came in for psychiatric treatment. As soon as we stopped the bodybuilding powders, these thoughts decreased dramatically. Granola bars, patients stopped dairy but forget to read ingredients. Cheese was one example of a girl who snuck out of her house after midnight, a 15-year-old girl who was so addicted to the casomorphine that she would sneak out of her house at night to get cheese from her neighbor. If we think of these morphine analogs, we need to think of addiction, which means withdrawal. So if you stop these cold turkey, patients might have cravings for food. And then the coffee mate is just another example of someone who is pretty much craving coffee mate because it's a very high source of casein, which means casomorphine. So lots more we can talk about, but I do want to share dysbiosis, elevations of the Clostridium metabolite, HPA. We've also seen associated with many neuropsychiatric symptoms, but OCD not uncommon. So if we try to understand this, and we've talked about this, in the past, multiple 4 to 5 pounds of bacteria in our gut. There's a trillion cells and hundreds of species of Clostridia. Well, as a metabolite, some of these Clostridia produce this chemical you see here in red, HPHPA. So HPHPA, let's see if I have it, inhibits this dopamine beta hydroxylase enzyme. So it prevents the conversion of dopamine to norepinephrine. So we get this buildup of dopamine. Now, the most common symptoms I've seen is kind of irritability, agitation, anger, sometimes rage, sometimes schizophrenia. We've also had patients with just OCD, pure OCD, with elevations of HPA. And when the HPA is treated, we know, and it's the only intervention, with high-dose probiotics or vancomycin or flagyl or other ways we treat elevations of HPA, that the OCD improved. For some kids, completely resolved itself. So I've seen a number of cases treating HPA improves OCD symptoms. So we have Clostridium metabolites producing HPA, inhibiting this enzyme. These metabolites, they not only use up glutathione and make individuals much more susceptible to many other toxins in our diet or in our environments. So we often don't think of the gut as a source of our OCD, but we've seen it for many, many years. The microbiome is a kind of symbiotic relationship. This is my clownfish and the anemone. They can't live without each other. And the same with many of our bacteria. We can't live without our trillion bacteria in our gut. But the bacteria can produce metabolites, HPA being one, that can affect serotonin. Here's another case. 12-year-old with physical tics, OCD, hand washing, hair pulling. I do want to digress a little bit, talk about hair pulling, trichotillomania is the name, and we've had a really dramatic success with high-dose probiotics. Sometimes we see the HPA and Clostridia, sometimes we don't, but 75–80% of the time, the high-dose probiotics have been able to make a huge dent in the trichotillomania patients. Here, overly concerned at swine flu, multiple outpatient exposure, therapy for 2 months, symptoms subside but recurred after panic attack watching zombies. So he came to see us on Prozac 20 milligrams. So, for Andy, it wasn't one thing. It was pretty much a combination. Magnesium, we didn't talk about, but critically important for anxiety, but for Andy, B12 is low. We used inositol with the Prozac. He had elevations of casomorphine, so we eliminated dairy. It's hard sometimes with these kids. Andy was just 12 to completely eliminate dairy. They go to parties or in school. So that's why I think it's critical that DPP-4 is part of that process. And probiotics. So this was a course of treatment where it was integrative. We kept the medication, went down from 20 to 10 milligrams, as I was concerned that the Prozac was actually aggravating some of the behaviors, creating some of the anxiety. But over time, and here we followed him for months on this program, really a very, very impaired male, young boy with OCD, hand washing 40 times a day, unable to be touched, and pulling out his hair where he's had patches. Pretty remarkable improvement looking at an integrative model. So I just want to kind of go over, I went through a lot of things very quickly because there's so much really that we could talk about, but we haven't talked about OCD for a number of years, so I just wanted to let everyone know that OCD is treated with integrative psychiatry. OCD is more common than I think we believe. It's the fourth most common psychiatric diagnosis in the U.S. Most of us believe it is underdiagnosed and undertreated. Many individuals, again, that have just the obsessive thinking, they don't think they have OCD, or just the compulsive behaviors, and some of these other disorders, hypochondriasis, polydysmorphic disorder, eating disorder, are kind of hidden in undiagnosed OCD. So it's very common. And our current treatment models, medication, partially effective, cognitive behavioral therapy, partially effective, and it's quite clear to me the combination of all three, medication, CBT, and nutritional interventions, is what can really create a platform where these kids and adults will begin to show more dramatic improvement. We talked earlier about the different kinds of things that can cause neurotransmitter deficiencies of serotonin. I mentioned a little bit about genetics. I mentioned a little bit about nutritional deficiencies. We talked about vitamin D, B12, folate, magnesium, zinc. What I didn't talk about was inflammation. Inflammation is quite common now. It's a buzzword for every major illness, and psychiatry, like every other area of medicine, is growing in its appreciation of how inflammation affects the brain and how inflammation can affect neuropsychiatric disorders like OCD. The mechanism is quite well known. We know that the cytokines, the inflammatory molecules of the immune system, produces an enzyme, and that enzyme is called IDO. And IDO actually degrades tryptophan and degrades serotonin. So we have this decrease in tryptophan, the precursor. We have this decrease in serotonin, essentially, and OCD and other neuropsychiatric symptoms are not uncommon. When we look at treating inflammation, we look at our typical nutraceuticals, magnesium, omega-3s, curcumin being the most common that I use. But in our OCD cases, we have to look for the underlying cause. And that underlying cause could be things like vitamin D deficiency. Vitamin D both supports the synthesis of serotonin and regulates the immune system. So when vitamin D is very, very low, we get more inflammatory markers, and potentially in those with a genetic vulnerability, we're going to get more OCD symptoms. My point being, there are many paths to low serotonin. There are many paths to understanding the gut, as well as our GI tract and digestion, to begin to trace where OCD might have some of their roots. So this is going to be my last slide. I'll be happy to stay and answer any questions. The concepts that we're trying to develop in integrative psychiatry is that here, OCD, if you will, mental illness, seen as a reflection of multiple errors in physiology. I gave the example of someone with a vitamin D of 9, maybe a magnesium deficiency and a B12 deficiency. If we begin to look at the causes, it could be 1 or it could be 6. It could be a digestive problem as well. Then we can start to look at cures, and we can kind of move away from the Band-Aid approach that our psychopharm model has. Just treating symptoms without looking at the underlying etiology. And that's why medications have not been as successful as we like for OCD. So again, if we find the cause, we may find the cure. And then prevention is possible. The integrative model looks at genetics and vulnerability. OCD is very, very highly genetic. So if we have mom and grandmother with pretty significant OCD, then we have a young child. We can begin to look at vitamin B12 and D levels early on. We can look at digestion in the gut early on. We begin to make interventions to help prevent some of the debilitating symptoms. As a psychiatrist treating patients close to 30 years, I can tell you some of the most tragic cases I've seen is OCD. Long-standing untreated OCD patients begin to get comfortable that irrational thoughts they had when they were younger, that I shouldn't be washing my hands 40 times a day, becomes normalized and very hard to treat, either in psychotherapy or medications or even nutritional interventions. So I'm a strong advocate for a biological foundation with aggressive CBT early on for the treatment of OCD. Again, the CBT literature is quite clear, and we have the PET and SPECT scans to demonstrate changes in the brain with cognitive behavioral therapy for OCD. So these are the books that we've done on integrative psychiatry. We have not written about OCD, but depression, eating disorders, and ADHD. Oh, and here I just wanted to share that we have the video conference on the first annual ADHD Integrative Psychiatry Conference. Dr. Hallowell, Ned Hallowell, Dr. Shaw, Dr. Jay Lombard, and myself. So it's a 6-hour video conference that you can download on Integrative Therapies for ADHD. And then, yes, I do have an email. So the J. Greenblatt at Walden Behavioral Care, if you do have questions, I'll be happy to answer it. Or you can sign up at the Finally Published Book or James Greenblatt website, and the contacts there. Be happy to answer your questions. Again, I appreciate your time this afternoon, and OCD is a really classic example of a serious neuropsychiatric illness where we do not need to go to psychosurgery. There's some incredibly effective integrative strategies. Sometimes medicine is needed, sometimes not, but there are tools out there to help our both young kids and our adults suffering from OCD. So again, feel free to email me with any further questions or look at the website. Really appreciate your time this afternoon, and good luck. Integrative psychiatry takes time and patience, we'll also be setting up supervision groups for those interested, because oftentimes it takes working with many cases to I really appreciate the complexity. Thanks again.